Welcome, all of you, those who have joined in now. So, Assalamu alaikum and very warm welcome to all the candidates. The purpose of this webinar is to give you some introduction regarding the MRCPi exam, OB-GYN exam, which you all have decided to take the exam. It's a very doable exam. So, give you some information regarding the exam. I'm sure most of you already you are familiar with the two parts of the exam, the written exam and its part two, and then the OSCE exam. So I'll give you some introduction regarding the exam, and also we'll talk about today how do we run the course at Med Exam Expert. So there are different activities. Already we have started the activity for the OSCE group. So there are some activity is the pre-course activity, which means that we start about half a week or earlier than the regular MRCPI OSCE course. And in this, we just randomly we practice stations from try to cover all the modules. So each day we'll have a different module. Of course, a case will be posted. I'm posting the case already, but nobody has up till now responded. So I would encourage you all to please respond well in the groups, participate actively, because this is for your help, for your benefit. Okay. The more you will practice, the more you will learn. So, one second. Yes. So believe and achieve. So the very important thing is to believe in yourself, and this is a very doable exam, as I've told you earlier. So once you must stay confident whether you have enough time for preparation or no. I know most of us are working, and then it's we have families and friends, work commitments, so it's difficult to take out time. But now, once you have decided to take this exam for the post graduation, and you have to organize yourself, and above all, it's very important to stay confident and believe in yourself. So half of the you are already achiever. Once you start to believe that okay, by this date I will have the degree in my hand, believe me, you will have it. Okay. So moving on to the next. So what are the objectives of the course? So the Med Exam Export course is designed for the candidates because it is relevant to the exam. All our courses are very well designed. As I was starting to tell you, we have pre-course activity both for the written exam and for the OSCE exam, and then we have a regular course. So the regular course is, although the exam is not module wise, but it is we have designed the course according to the module. It has two benefits. Number one, it will cover all the stations, and you can also divide your preparation time according to the module so that you cover maximum topics. Secondly, most of the people or the candidates who are taking MRCPI, they are also taking the MRCOG exam at the same time. So this will also help them for the MRCOG because that is basically a module-based exam. Okay. So we have a Telegram group in which there will be a pre-course activity and then the regular course. There will be a schedule is already shared on the Telegram group, and it will be shared in the various groups as well, also on the website. So according to the module, then we will take the session. There will be live sessions for the written exam and for the OSCE exam. So the written exam practice for the SBAs, there are two, or I think, or three groups in which is run by my colleagues. And I would those who are taking the written exam, I would advise them to please actively participate in those groups. Take out time, even if you are busy, but you have to make a timetable and take out a slot for your preparation for the exam. Okay. Staying focused is very important. Then we have structured revision classes. So we repeatedly testing you using the exam questions. So there will be recalls. If practice is basically on the recalls, then we have discussions in the live sessions. We also offer in the end some boot camp, as you have already those who are preparing this time in the written exam, they are familiar with that. That this will be a 3 days like a fast track course for the SBA practice in which all the records of the past 10 years we have practiced. So this is how it works. Regarding the OSCE, we also have a long session near the exam that will be a grand round session in which you will have more discussion about the labor ward scenarios and also some difficult stations like breaking the bad news, and also regarding the labor and delivery, like conducting different deliveries and obstetric emergencies. Okay. So all the information is on the website. On the website, you have summaries for the TOG articles, summaries for the Irish guidelines, for the important NICE guidelines as well, and some RCOG guidelines as well. Also, the leaflets are there. And the recorded sessions are already there for you. So there's lots of supporting material. Both on the Telegram for the written and the OSCE, we have guide study material group as well, in which I for the OSCE, I'll be the one I'll be sharing with you related guidelines and leaflets. Okay. So at by the end of the session, if you have any questions, we'll take it by the end of the session. So online sessions are starting pretty soon for the May exam. Sorry, it's not the March, it's the May exam now. So study room practice will be there and Telegram daily practice group, which I've already told you. So pre-course activity, which we have already started, then daily module wise we'll practice. There will be live sessions, there will be ground round sessions, and of course then there will be on-site mock. This time it wasn't possible because we have less candidates for the mock, so it was only online, but there will be on-site mock exam as well. Now the course structure, so as I've already told you, it is module based. We have scheduled live sessions, recorded lectures are available, mock exams, and you can always access to me and to my colleagues. If you have any doubts, any questions, you can send the message on the group and we'll reply on time. So So in the end of session today, you can discuss if you have any queries or any help. So what are your needs? What do you do? What are you struggling with the most? Come up with your answers, how you manage your time. If you want any advice regarding that, any suggestions, and any contents, anything. But the most important thing for you is to stay consistent. Okay. So because practice makes the man perfect. It's an old proverb. So remember that. Now, regarding the exam structure, as you're already familiar, so part two is a written exam. It's about a 3 hours exam in which we have 100 single best answers. You can do it from the comfort of your home. So make sure that you have a good internet connection, and they already the college sends you details regarding the requirements. So what are the requirements? The room should be clean. There should be no especially around you, they will check. They will ask you to turn your laptop up and upside and down under the table. They are checking with the camera. So the room should be with the minimum things in the room, so that it's spacious, and there should be a white plain wall behind you or a white board. Also, there should be you should have a backup internet connection as well. Okay, because if you have I mean, a week before exam, you should set your internet so that you are free of all these extra stresses which we have near the exam. Okay, don't leave the things for the last moment. Secondly, practice SBS daily in the groups. You need to practice. So, as I've said already, please participate actively. This time, we are going to keep a track of your activity. So, all the candidates, because some of the candidates they have a zero interaction, so which is not good. It will be an extra effort from our side and from the team to keep a track of your participation, but I think this will help you in the end. So we are going to keep a track of all the candidates in terms of their participation in in the written groups as well, and also for the OSCE. Okay, so fortnightly you will receive a report which will tell you where do you stand in as compared to your peers. Okay, so this will help you to improve yourselves, and I hope it will motivate you to participant. Also, we will be knowing who are the serious candidates who are really seriously considering their to improve themselves and who are the hard workers. Okay. So this is something new which we are not been doing so far, but in this sessions, this time for the May exam, we are going to keep a record of your attendances and your participation. Okay. So there's no negative marking in this exam. It's a very doable exam. You should also side by side read the guidelines. I say uh, important nice guidelines. There, all the summaries are given on the website. Also, the Irish guidelines, especially the recent guidelines, are very important, and contraception is very important. So you should know all the FSRH Quebec criteria, missed pill scenarios, emergency contraception. These are the typical questions which you receive. Infections are again very important from the exam point of view. Same goes for the medical conditions. So you don't have guideline for all the conditions, but the basic things, all the exam topics are covered. There are some important dog articles. Lots of questions for SPS come from the TOG regarding the surgical techniques like surgical complications, ureteric injury. There's a talk article on ureteric injury. Then there's a talk article on nerve injuries. Then about the incisions, headaches. Recently, there are articles on cervical trachelectomy and cervical cancer in pregnancy, breast cancer, HRT. So lots of questions come from HRT. So read those. There are three, four articles on hormone replacement therapy and TOGs. So go through them, please. This will help you for the exam. And also practice some SBS, standard SPA books. There are lots of books on SPS, so you can practice through that. So here, I know it's just from the website about the written exam. So the March exam is just in 4 days. Those who are taking the written exam this time, and then there will be a written exam in September. Okay. So this the opening date would be 3rd of June, and this is the exam fee. So this all information is there on the website as well. Moving on to the OSCE. In OSCE, it's a clinical exam, so it's a face-to-face exam. And another thing which we are going to do in our live sessions is that each one of you, whoever is participating or taking a task, should open your videos, open your camera, because this is a face-to-face exam. So I really personally don't like that you are just hiding behind the camera, not opening your camera. So I think if you must, everyone must take a face-to-face exam. So for me, in my live sessions, I will not accept closing the cameras. So be prepared for that. Okay. So there is a long case, and there are 7 stations for the OSCE. So there's a 10 minutes OSCE station for the long case. Actually, on the exam day, what they will do in OSCE, they will divide the candidates into two groups. So one group will go for the long case, and another group will start the circuit. So actually, they divide the whole number of candidates into two larger groups, and then each group is further divided into two groups. So there is a break time also in between, which is quite long. It's about almost 1.5 or 2 hours. So the batch who will have the first, they will have the long case, then after the break, they will have the circuit, which is the OSCE, which are 7 stations. So the long case is about 45 minutes. There will be 2 or 3 examiners. There's a role player. And you have to definitely, to pass the exam, you have to definitely pass the long case. The long case is either obstetrics or gynecology. So the candidates, for example, they are 20 candidates. So 10 will take the long case for obstetrics and 10 will take the long case for gynae. So either of the case would be, it's your luck, whatever you will get in the exam. So you have to introduce yourself. In the beginning, on the day of exam, you will be given a long list of stickers. So you keep this with you. Don't lose it during the break time and in panic. So when you enter, you will introduce yourself. You will say that I am, for example, I'll say I'm Dr. Khawar. This is my exam sticker. And you will give your sticker to the examiner. Because it's a small sticker, you will remove it from your paper, the strip which you will receive, and give it to the examiner. So the examiner will paste it on your answer sheet, actually, on the marking sheet. So it's very important. Then there will be the There are no board and no pasting of the papers outside the station as for MRCOG. So the station will be posted on the table in front of you on the desk. So go through the station, you read carefully. Don't panic. There's plenty of time for the long case. So just read calmly and focus on what the tasks are. And then there will be role player sitting beside. So you will introduce yourself to the role player, and then you will go with the taking the history and so on. So once you have done with the history, then on the other side of the room there will be a couch and there will be the mannequin. So examination is a must part, and there is a marking for the examination. So another examiner will be standing there to observe you. So you have to get up then and do the examination. So you have to perform and you have to tell the examiner at the same time that what you are going to do and why. Okay. And then in the end, the examiner, you will come back. Once you have summarized, you have done with the examination, you come back. And then the examiner who's sitting in front of you, there will be two examiners. So they will give you the examination findings, and then you will turn again towards the patient and explain to the patient the examination findings on your management. Okay, so this is how the long case goes on. And you have good 45 minutes for the long case. So there's plenty of time, but don't take half an hour for the history taking. Okay. We'll discuss further in the OSCE sessions when we'll do one-to-one sessions. So regarding the circuit, there are seven stations. There will be random stations, bell will ring, and each is for 10 minutes. So you have to be very fast. You can say that in those 10 minutes, you have to summarize the whole case. For example, you have 30 perennial tear. It can be mostly they are structured discussion, but there can be one or two role play stations also. So the role play stations might be breaking bad news or might not be. It might be just randomly a gynae case or an obstetric case, and patient is sitting there. So once the patient is sitting there, you have to be very fast. You will take a history, then you will enter in the same manner, introduce yourself, give your sticker, read the state task, and then turn towards the role player, and you will take the history. And then you have to give your differential diagnosis, examination, and logically for each whatever management you are telling or you are giving any investigations to the patient, you have to have a solid reason for that, why you are going to do that. I would suggest also practice when you are counseling the patient to draw the diagram to tell the patient. For example, if it's a fibroid, you can just tell the patient that this is the womb and this is how this is the muscle of the womb and this is the overgrowth. So it can be hanging inside, which would be submucous fibroid, or it is on the outer surface of the womb, which is a subserous fibroid. So on. I mean, like this, you can draw the diagram. You can draw the diagram for polycystic ovaries to explain what's that. So make it your habit to have a pencil and a paper in your hand and draw the diagram, and then you explain to the patient. Also encourage the patient to ask any questions, because if you have missed anything, the patient will ask her. So don't keep on talking yourself. Also, let the patient speak. Okay. In the end, especially when you have done with the history, you can ask the patient if she has any questions, and she will then ask you, or you can just quickly summarize if the time allows. Secondly, I would suggest in the Telegram groups also try to pair yourself, find a study buddy so that you can, if there is a role player station, I will specify whether it's a role player or a structured discussion. So far, we have put just a structured discussion, 10-minute stations, but sometimes you may have a role player station. So try to do with the role player. So this will help you in the final exam as well. Okay. So out of seven circuits, most of the times one is dedicated for the labor ward. In one or two exams, I think the labor ward did not come, but prepare it because it is an important component of the OSCE circuit. So labor ward prioritization will also be there. So this is the calendar for the OSCE exam. So there will be an OSCE on 22nd and 23rd. In May, it is in Ireland, Dublin. And the opening date is already there. It has opened from 25th of, February until closing last date is 25th March. And here is the fee for the exam. Then in May, this time also the exam will be in Muscat, Oman. Excuse me. And the fee will be more, I would say, because especially the candidates from Pakistan and also from Sudan, there is problem in having the visa. for Oman. So go for Ireland then. They are very nice people, and also after the exam, you may have, if you have time, you can enjoy. And I think don't take the chance or the risk of applying for Oman, then they are refusing your visa, and until the end of the exam, you are not getting your visa. It happened in the past as well with some candidates; they were not able to sit the exam. Some were sent back from the airport. So to avoid all that hassle, no need to apply for Oman. You can still wait and go for Dublin. If you don't get the seat, you can wait for November. Okay, there's good in everything. This is my suggestion. Otherwise, rest is up to you. Because everybody is in different circumstances. But I would say this is my humble suggestion that don't take the risk for visas because now war has already started. We don't know how it's going to end and when it's going to end, and there will be lots of restrictions. Already, we have restrictions. I myself am from Pakistan, and I know that I've also suffered, and many of my colleagues and friends they have suffered from visa a lot. So no need to waste your money and waste your and take all that extra stress. Okay, go for Dublin. So there will be another exam in November, and OSCE will be in May and in November. So yes, it's very, very important to make a study plan or a timetable because you know how many weeks you have to complete the course and keep the last 2 weeks at least for the revision. Okay. For the written, I would say also similarly plan your leaves because if you are working, you need to apply for leave. So apply for leave in advance so that you don't have that stress. And you know that if you have like 2 weeks, no need to take very long leave, but 2 weeks for the written exam, I think even 1 week or 10 days is good enough. If you've been practicing regularly in the groups and you are practicing on your own with any SBA book, just make go through the guidelines once, and there is a very good quick summary documents. But for the written exam, I would say that read the details of the guidelines once, make your own notes because there are small points which you don't find in the quick summary document. So once you are done with the with your summaries and you have prepared them, then no need to each time if you are doing a topic to go back to and open the guideline. Okay, make your own small notes and practice daily. So 10 days, 7 to 10 days leave for the written exam would be good enough if you have been working and practicing regularly. And inshallah, you'll pass the exam. You will sit in flying colors. For the OSCE also, same goes for the OSCE. No need to sit at home and then just practice. You can do daily practice on your patients while you are taking the history. Make sure that you take a complete history. You can time yourself in your clinical practice so that this will help you for the exam. Also, participate actively in the groups. Find a study partner. It's very important to have somebody which keeps you motivated as well. Also, you can clear your doubts. You can be the examiner. She can be the candidate, he or she, and your partner or your friend, whoever with whom you are studying. You can make a small group as well. So it's very encouraging, and also you retain more when you discuss. So short focus study blocks. So if you don't have like too many hours, at least in the beginning, if you have like 3 months in the first month, even if you take out time, for example, let's say dedicate 1 hour for your study, 1 to 2 hours in the beginning is very, very important. Whatever time is acquired time for you, whether it's in early morning, late night, some people study better in early morning, some study late at night, but do have some dedicated slot for your exam preparation. Okay. For the written, if you take out like half an hour, 40 minutes, or 1 hour at least, would be very good because you can say, for example, if you have for the written exam. It's a vast course, but it's again clinical. So, for example, if you are doing contraception, you can make a timetable that, okay, I'm going to cover the contraception in next 3, 4 days. Okay, so 3 or 4 days are good enough. Then you do contraception SBAs from all the SBA books. Then you go through the FSRH guidelines. So you should know about different types of contraception. What you should know, what is the mode of action, what are the times, what are the contraindications. I mean, you can make criteria. Then what are the side effects? What are the failure rate? What are the success rates? Then you should know about luck. You should know about the postpartum contraception, what we can offer, and also there's a guideline for that. You should know missing pill, what pills are missed, and what to do in that case, what to do for the breakthrough bleeding, and also about the emergency contraception. We have three methods, like we have levonorgestrel, we have ulipristal acetate, and we have IUD. So when which one is the most favorable regarding the LMP, regarding the situation? What is the mode of action? Because you get questions on that. Okay, how do they work? What is the success rate, failure rate? What happens with the patient moments within 3 hours, 4 hours? A drug interaction is very important in contraception. Enzyme inducing drugs, lots of questions come from that. So, then contraception in aged patients, like in advanced age patients, what you can do, give. Yeah, so in this way, you cover the topic from all the aspects. Okay, so this will be a good preparation then. And in your final closer to exam in the last 2 weeks, then you can do your revision, and we'll also be with you. We'll do the fast revision circuit as well. So, what are the universal rules for study plans? So, consistency beats intensity. Okay, so consistency is very important. So, in the beginning, you can keep 2 to 3 hours daily, dedicate that for the exam. Don't skip the session. So I have seen that people, they we see a long list, but only few are participating or attending the session. So you have the timetable from now. So you can just, if you have calls or duties, you can make arrangements, alternate arrangements, swap with your colleagues, so that you have free time. You have paid for this session. And I know it's a hard earned money. So for most of us, so no need to waste your money. So take out the time to please attend the session. I know there is a facility of recorded sessions, but believe me, recorded sessions, listening to the recorded sessions will not help you that much. It will be helpful, but not that much. So the best thing is to participate yourself actively and be present in the Telegram groups. As I've already told you, we will keep a record of your attendance, of your participation, and we will share it with you. Follow the 50-30-20 rule. What's that? 50% is the learning, 30% is the practice, and 20% is the revision. Okay. So you will learn only if you will participate actively. So, in the webinar, our tradition, we cover a topic. We just go through some important topic, which is important from a written and OSCE point of view. And then we will do a discussion. So, I will have a volunteer to do an OSCE station, which would be a 10-minute station. And then we'll practice some SPAs in the end. Okay. And after that, I'll take your any question answers. So, what is menopause and what is postmenopausal bleeding? Menopause is defined as the final menstrual period, which is followed by 12 months of amenorrhea, and the median age ranges from 50 to 53 years. I hope you all know that. And what is the postmenopausal bleeding? Now, this is according to the Irish guidelines. Postmenopausal bleeding in women not taking hormone replacement therapy is defined as an episode of vaginal bleeding occurring 12 months or more after the final menstrual period. Correct? So, abnormal bleeding in women taking hormone replacement therapy. So, what about those who are taking hormone replacement therapy? So, one thing is decided by definition, it should be any bleeding which is after a period of 12 months from the final menstrual period. So, when to investigate if somebody is taking the hormone replacement therapy? So, this is very important. A patient should be referred for investigation if the bleeding is persistent while she is taking the hormone replacement therapy. So, if it's for sequential hormone replacement therapy, should be referred for investigation if they experience bleeding despite adjustment more than 3 months of commencing the treatment, or if the bleeding has increased, it becomes heavy, or if it is prolonged. And what about continuous combined? If somebody is on continuous combined hormone replacement therapy, then any bleeding exceeding 6 months, as we know that it's common to have some irregular bleeding in the first 6 months, or if the bleeding occurs after a period of amenorrhea, and especially if there are any additional risk factors for endometrial cancer. And all women with abnormal bleeding on tamoxifen should also be investigated. Okay, so what is the differential diagnosis for the postmenopausal bleeding? So, as there's bleeding, so it can be any It can be benign causes and it can be malignancy. So any non-benign gynecological conditions, it can be from the vagina, it can be from the endometrial atrophy secondary to estrogen deficiency. As we know, very common cause for postmenopausal bleeding is atrophic endometritis. So it can be endometrial cervical polyps, uterine prolapse due to ulceration, endometritis, endometrial hyperplasia, and then gynecological cancers, endometrial cancer, vulval vaginal cervical cancer, or it might be due to non-gynecological conditions such as urinary or gastrointestinal. What are the risk factors for endometrial cancer? So, endometrial hyperplasia and endometrial cancer are commonly associated with multiple risk factors. And what is the aim or what is our fear? Our fear is for the endometrial cancer. So, we need to investigate and we need to identify the risk factors when we are taking the history. So, we need to know if the patient is taking unopposed hormone replacement therapy, which will increase the risk of endometrial hyperplasia if she's on tamoxifen, advanced age, obesity, or if there's any family history of colon cancer or hereditary non-polyposis colorectal cancer is a risk factor as well. So how do we manage? So management step one. Can you see the slide clearly or shall I zoom it out a little bit? Is it better now? Hello? So step one, a woman recognizes so should be refers to the so to us, patient will come referred from the GP, okay? So an urgent history need to be taken, abdominal examination. So once you have taken the history, then you have to do the abdominal examination, speculum examination, and bimanual examination should be done. And if the urgent referral should be done to so this referral would be already done by the GP, but for the written point of view, you should know that what is the window period, what is the time period, which is within 28 days, patient should be seen. So urgent referral to the local specialist postmenopausal bleeding clinic. And if the bleeding is suspected to be urological or electrical, then appropriate referral within the hospital services should be done. If there is a suspicion, then direct referral to the gynecology oncology services should be done. Look at this line. So if there is a suspected lesion for cancer on the cervix, vulva, vagina, then direct referral to the gynecological oncologist. Referral is received. This is the pathway told by the guideline, Irish guideline. Referral is received by the hospital services, triage, and appointment is given ideally within 28 days, where the patient should be seen in the one-stop ambulatory services. So urgent history and in-person examination is very important. So same day postmenopausal referral to local gynecology. So fast track postmenopausal bleeding. What is the referral would be by the GP, urgent referral. Patient should be seen by the same day, but until 28 days, she should be investigated. So this is the window for the ideally within 28 days. So all the triage and everything should be done by 28 days, but should be seen in the same day. So past medical history, if she's taking any hormone replacement therapy, anticoagulants, and then any anticoagulants if the patient is taking, how long she was not having a period, whether she is still like it's already 12 months or more, then other medical history of the patient, surgical history, her performance status, whether the patient is living alone. This goes especially for the very old, fragile patients who is taking care of them. What is their mental capacity, whether they can give consent, all these things you have to assess in history and examination. So, how the woman should be investigated? So, detailed history, physical examination, and ultrasound and hysteroscopy are the main. Then we do the transvaginal ultrasound, image to see the endometrial thickness, and and we have to take the sampling as well. So, endometrial thickness measurement is obtained by ultrasound in the mid-sagittal view of the uterus by measuring the maximum anteroposterior thickness of the endometrial echo perpendicular to the midline, okay, without involving the endomyometrial junction. So accordingly, then we have to go for the hysteroscopy, guided biopsy, or we can do an outpatient pupil biopsy as well. So there's a lack of consensus for the cutoff. So the many questions you will receive, you will get in the exam, few questions regarding HRT and the cutoff for the endometrial thickness in postmenopausal bleeding. So these ranges from 3 to 5 millimeters. So a recent committee opinion by American College ACOG, what does it say? 4 has a 99% negative predictive value for the endometrial cancer. So the Australian Society cutoff is also 4 And what does NICE say? Also 4 to 5 millimeter. A cutoff of 5 millimeter is also recommended. So stick with the guidelines. So transabdominal can be a complementary ultrasound to transvaginal scan. Endometrial sampling. So definitive diagnosis, of course, would be by histopathology. So in the case of patients who are on tamoxifen, then endometrial thickness measurements are not useful. So you have to go for endometrial sampling for patients who are on tamoxifen. We know that now dilatation and curettage is not the first line, not so favorable. So we can do either pipal or the endocurate or the hysteroscopic guided biopsy can be done, especially for the high risk patients. Hysteroscopy, what is the benefit of hysteroscopy? Hysteroscopy facilitates the visualization of the uterine cavity and it's considered the gold standard in identifying the endometrial pathology. Furthermore, it allows for endometrial sampling and treatment of certain endometrial pathology. Hysteroscopy has been shown to be superior to blind endometrial sampling, especially if there is endometrial polyp, there are adhesions, there is focal pathology. So all those high-risk patients, hysteroscopic guided biopsy should be done. Now, this is the algorithm from the guideline. I'm not sure if you can read it. Is it clear now? Somebody should tell me. Open your mic. Dr. Najla, is it
Not
clear?
clear. No,
Okay. No, not clear. So if we
no.
zoom it out now, it's out. Actually, I will try to read out because it's the same thing which we have already discussed. It's a summary. It's there in the guideline also, this algorithm. So take a thorough history and examination. This is from the GP will diagnose the postmenopausal bleeding and bleeding not vaginal in origin. Then GP management or onward referral, as we said, according to the hospital. So vaginal bleeding, if patient is on sequential HRT, or bleeding is heavy or prolonged in duration, we have already discussed this, or if the patient is on continuous combined HRT, then what when you have to investigate, or if somebody has recurrent with a postmenopausal bleeding. So this GP referral, then this is the triad system, which weekly or twice weekly review of the cases should of the referrals are done, and the triaging should be done within 28 days. We have already discussed this. And the one-stop ambulatory clinics is the best because there they can be assessed at the same time. They have a consultation and they will undergo the endometrial sampling or hysteroscopy in the one-stop clinics. And the patients who are unable to comply there and to complete their investigations in the ambulatory clinic, then they will be referred to the hospital services. Okay, so this is about the algorithm. Now, I want a volunteer who is going to take the case for 10 minutes and then we'll do SPAs. After that, we'll close. Anybody who wants to volunteer? It's not an exam, it's just a friendly discussion. I'll put the timer. I'll be your role player. Come on. No one? We have Samara, we have Dr. Najla, we have these two of you. There was Dr. Sharif as well. I think he's left. Saima Rashid. Anybody? No? If you don't want, then I'll skip it. No one wants to volunteer? Hmm? Why you are scared? Okay, no problem. Let's go to the SPS. We have any candidates who are taking the written exam? Hello? Open your mics, please. No one?
It's
Uh,
124 per thousand.
Dr. Sama, you are for the written candidate?
I'm for OSCE.
You are for asking. So Yeah, I know. I don't want to know the answers. I would just a friendly practice in the webinar, actually.
Yeah.
So if both of you and can see Dr. Najla also, is she also for the OSCE? Okay, then we are going to skip this part. If we don't have any candidate for written exam, it's fine. Any questions you guys have regarding the med exam courses or regarding the exam? I would be happy to answer. Yes? No questions? Any suggestions? Any comments? Hello?
Hello, ma'am.
Yes, ma'am.
Yeah, I'm Dr. Miruna, but I'm working in OPD, so I don't know how long I can continue. Maybe you can, if you can go back to that scenario, I can try.
You are for asking?
Yes, ma'am.
Very good and welcome. And I'm so happy. See, this is the thing I'm talking about. I've been talking that please, please, please don't be shy. Come up because we are all the same and there's nothing wrong. If you will make mistakes, mostly people do very well. So just stay confident and participate. Okay, then I'll be your role player. Then quickly, will you have only 10 minutes? So you have to take a history and explain the causes, explain the reason to me, and then any investigation, then how you will talk to me about my bleeding. Okay.
Okay, ma'am.
Shall we start? Okay, yes. Go.
Good morning. I'm Dr. Miruna.
Open your camera if you can, if you don't mind, please. You can see you.
Am I visible?
I don't know how I can see. I don't know.
It's showing unable
The
to
screen
access
and you can
camera.
do as well at the same time.
Maybe from the
Uh, you have opened? No, I can't see
no,
you. I
ma'am,
can't
I
see
can't.
myself.
Or maybe I have to log in with another device.
Okay, no
Um,
problem. Then we'll continue with the
okay,
scenario
I
like
can
this.
continue. Yeah, okay, ma'am.
Okay.
Okay,
Okay.
should I start?
Okay. Yes, yes, please. Thank you.
Okay. Good morning. I'm Dr. Miruna. I'm working in the clinic as a registrar. I want to help you. Can you confirm your name and age?
Yes, I'm Cynthia. I'm 58 years old.
Okay, good to see you, Cynthia. So I heard that
Thank you,
you are
doctor.
58 years old and
Yes,
you have vaginal bleeding. So I want to ask some question.
it's okay.
Okay. Cynthia, when was your last? Is it Cynthia okay if I call you Cynthia?
Yes, yes, it's okay.
Okay. When was your last menses? Like means your menopause? It stopped when?
It stopped when I was 47, doctor. So long time ago.
Okay. So in last 11 years, you never experienced this type of bleeding.
No, I never. It's the
Okay.
first time, but it's last like 3, 4 weeks. I've been having some. I noticed some brownish discharge. I had a little pain in my lower tummy and a backache. And then when I went to washroom, I peed. I saw I cleaned myself. I see some spotting, some brownish discharge. And 2 days back, it was a bright red blood. So I was a bit scared and went to GP and he's referred me to the clinic. Uh,
Mm. Any other associated problem? Any lower abdominal pain? Any tummy pain or any itchiness? Any other discharge?
I don't have any itchiness or discharge, but I do have pain. It's not all the time, but sometimes it's. I notice when I have pain, I have some bleed as well.
Okay. Any urinary or bowel complaint? Do you have? How is your bowel habit? Is it regular, or when you pass pee, do you face any problem?
Mm, no,
Okay. Do you have any other health problem like hypertension, diabetes, anything?
Yes, I'm hypertensive.
Okay.
I have high blood
Any
pressure.
okay, also hypertensive and high blood pressure. Are you taking any medication?
Yeah, it's the same thing. Yeah. Yes, I'm taking.
Okay. Do you have any family history? Your mother or your sister, do they have any uh, cancer or any
Yes,
other problem?
my mother has breast cancer.
Okay.
She is hypertensive and diabetic also.
Okay. I want to take your past obstetric history, that how many kids you have and how did you deliver them?
Yes, I have two kids and they're delivered normally.
Okay. So you were on contraception for a long time?
Yes, I had a loop, but then I took it out for after 3 years, 3.5 years, I guess. Yeah, and then my partner used condom, and that's it.
Okay. Any other gynecological or problem, or do you have any operation, history of any operation beside that Caesar?
No, I never had any surgery.
Okay. Also some personal history. Do you smoke or do you drink alcohol?
No, I don't smoke. I don't take alcohol. I don't smoke.
Do you have allergies?
Yes, I have allergy to sulfur drugs.
Okay. Actually, this vaginal bleeding is how long? You said like is 1 week history on 1 month.
It's almost like 2 to a few months, 3 to 4 months, off and on I am having, but last 2 days I had some bright blood.
Okay, I am Cynthia. I want to do some examination. Like I want to
Okay,
see, yeah, I want to see, do you have anemia? Do you have any other skin problem or your
okay,
vitals, like your blood pressure, everything is okay? I want to
right.
do some thorough yeah, examination. I also want to examine your tummy and your private part, some
Okay.
speculum examination, and also a
Um,
bimanual examination.
okay.
Okay, and after those examination, I also want to do some investigation. Like if you are anemic, then I want to do a full blood count and also
Okay.
a ultrasound. I need to check how is your uterus to exclude that you don't have any ovarian problem or everything is okay.
Right.
And
Right.
by the speculum and manual examination, I also want to check your cervix that is fine and there is no local lesion, no local skin condition, no other
Fine.
STD. I
Okay.
have to exclude all those things.
Yes. Mm-hmm.
And after
So,
the investigation, I can maybe tell you that what is the problem.
yes. So can you just tell me, because I was checking, this is the AI, uh, era and everybody's taking information. So I was just thinking and I also checked and it really scared me that, do I have a cancer or what do you think is causing me bleeding off and on?
Okay, I can assure you that most of the most common reason for postmenopausal bleeding is um, just maybe the erosion or we call it itis, like either atrophy. Due to lack of hormone, we have some vaginal atrophy or cervical atrophy or
Right.
endometrial atrophy, which can causes the bleeding, and also
Okay.
sometimes associated with the infection, any
Mm-hmm.
vaginal cervicitis or any cervical pathology. We need to exclude all those things. These are the
Mm-hmm.
main. But beside this is, yes, also there is some
Mm-hmm.
changes in endometrial hyperplasia, but it is still a benign condition, is not a cancer. This one also can cause the bleeding.
Right.
Yes, there is also chances of cancer, but it is very less. But we are also going to exclude all those things. If need, if
Right.
your ultrasound report is coming that your endometrial thickness is more than 4 millimeter or 4 millimeter, and
Mm-hmm.
and then maybe we will do a biopsy and then we
Okay.
can exclude that you don't have cancer.
Okay, doctor. So it will be on biopsy, you will decide, right? So what
Yes.
treatment I must take then, or will wait for the ultrasound result? Will I have to remove my womb?
If we say endometrial hyperplasia,
Mm,
benign
mm,
hyperplasia, then we can go for some treatment. Like we
mhm.
can use the hormonal treatment. It maybe the progesterone oral therapy, or we can also
Okay.
insert a device like Mirena coil, which one can
Mm,
also has progesterone. It will release and help you to shrink your hyperplasia. So
okay.
we will follow up you in that time, like 6 monthly. We'll do the biopsy and see that how is the condition, how the disease is regress or it progress. So according to that, we'll take decision. But
Right.
if the
Very good.
hyperplasia, yeah, is not
Mm,
benign as something virulent,
mm.
then we may decide that we will go for surgery.
Okay. Very good. You have 40 seconds. You can close the station.
Okay, thank you, ma'am.
Mhm.
So this is that we are going to again. I can come that your case that at your age you don't have your physical condition, you are good. So after examination, after checking if you have some vitamin problem or you have some local infection or your result, it will depend. Will take care you. But if you need a referral, like your report, then also we will refer
Okay.
you to
Time is up.
special
Time is up.
oncologist.
Okay. Thank you so much, Dr. Meruna. Meruna, how do you
Yes, yes,
pronounce?
ma'am.
Meruna. Very well done. I'm so happy. Thank you so much. Good
Uh,
attempt.
thank
You
you.
were not prepared and you did it very well. So, how do you think you did? You feel after doing the session, the
Uh,
station? What is
I
your
think
feeling?
I was I was spontaneous but not structured. I need to structure my things a little bit. Uh,
I
but
know
uh,
you started all right. Yes, your introduction was good. You were confident. Yes. Hmm.
yeah,
You
I
were
need
very
to read
polite.
the topics again. I think I forgot because uh, it's more than 1 year. I passed the written exam and now I'm working
No,
on
no, it's okay. It's
pediatrics.
very simple. And
Yeah,
if anybody will come, if you are practicing or working in a clinic or in
yeah,
a hospital, in your OPD, if you find any postmenopausal bleeding, the first thing we advise is to do an ultrasound, a transvaginal scan to see the endometrial thickness. And this is very important. And mentioning about the biopsy, which you did. Anyways, very good. You did fine. I'll have few suggestions. Firstly, we'll go with the history. Your introduction was good, then history was good. Just with few things. Whenever we are thinking about cancer in our mind, please don't forget to ask about the red flags like anorexia, weight loss, any lump is she feeling in her tummy, or the tummy is becoming bigger, bloating, right? Then
yes,
I
ma'am.
think sexual history you forgot, so make it
Yes,
your template in your mind on a paper as well. Then in gynecological history, when you are done with the see how do we go with the history? This is for everyone. It's the same history as you learn from third year. So you go with the history of when there is presenting complaint, history of present illness. Once you are done with the history of present illness, which will include few points, few sentences regarding the presenting complaint. As you asked very well, you asked about pain, bleeding, how much is the bleeding, how frequent is the bleeding, what's the color, amount, and any abnormal discharge, itchiness, urinary bowel complaints, all you asked. In this, you can add if they are thinking of cancer, whether it's ovarian cancer, cervical, or any endometrial cancer, any history of weight loss. Have you noticed any weight loss? Unexplained
mm,
weight loss or unintentional weight loss? How's your appetite? Just these two questions. Then
yeah,
you go to the gynecological history, in which you will include the menstrual cycle, which you asked, confirm the LMP, then contraception, which you asked, and then don't forget to ask about the cervical smear, and also then the sexual history will come. So I think you omitted sexual history. You forgot to ask if I'm sexually active, if I have any postcoital bleeding or any pain, because this is
yes,
also important. Okay, and smear, don't forget in gynecological history.
yes,
When was your last smear and was it normal? So maybe she has some hidden agenda or some hidden history. Then obstetric you asked, which was fine. If a patient is younger in gynecological case, you will ask whether family is complete, whether she plans to have more babies or no. And then you come for the medical surgical allergies you asked, which was very good. Family history of malignancy you asked, that was also good. Social history, occupation is also important. And medications, I think you did not ask, besides hypertension, if I'm taking any other medication, right?
Mm.
Because if I'm taking anticoagulants, it can also cause me some abdominal
Mm.
bleeding. Rest examination was fine, abdominal and speculum examination. So if it's a long case, then you have to elaborate on the examination, but in 10 minutes, there's no time. In investigations and all, that was good. Okay, so overall good attempt, very nicely done. And thank you so much.
Thanks, ma'am.
So this brings us to the end is we don't have anybody from any written candidate, any candidate for the written exams, and we'll close this session. If any questions you people have, any queries? Yes, and Dr. Maruna, and for the rest also, please avoid using medical jargons. If like you're saying endometrial hyperplasia, don't say. You can say that we will see if the lining of the womb, endometrium is the lining of the womb. Then if it is hyperactive, okay? If the cells are hyperactive or the cells are increased in number, or if there's any abnormal growth like this. For in Conje's book, there's a lots of Conje Part 3 book. There are lots of explanations for the medical terms in layman language. You can go through that and try to find an alternate. So biopsy maybe everybody will not understand. So you can say we'll take a few cells as a sample of the test to see if there are any abnormal cells. Okay. So try to avoid medical jargons.
May I know
Right.
what schedule would be followed in the group and from which date?
Dr. Saima, already we have started the Telegram group for May exam, May OSCE exam, and pre-course activity is going on. So it started on Friday. So Friday I was traveling, so I posted yesterday stations, and today's station also I posted. So after that there will be a regular course. I've also posted the schedule in the Telegram group. So the team will also share with you, so you can go through that and you can follow. For this is for the OSCE. For the written candidates also, same is ongoing. I think pre-course activity maybe if it has not started, it will start pretty soon, and then there will be the sessions. So all the dates for all the sessions are already there. If you want me to tell you now, I will just open for you and let you know. Just bear with me for a few seconds. Yes.
Mom,
So the
Mom, I
first
will ask, you have mock course or no?
mock exam will be there. Yes. Mock exam will be there. There's online mock and there's a face-to-face on-site mock as well. So this was the
Okay.
webinar today. So the first session will be taken by me. This is for the OSCE, which will be on 15th of March, Sunday. It is on antenatal care and early pregnancy. Then on 24th of March, you have oncology session by Dr. Musarrar. Then 30th March, I will be taking maternal medicine. Okay, so for maternal so what happens, answering to your question, Dr. Sama, pre-course activity will end in 1 week. After that, you will have a regular prep course until 14th of March. And 15th will be the live session regarding antenatal and early pregnancy stations. Okay.
Will
So
it be
what I'm going
possible to, sorry, will it be possible to cover whole of the two modules in just 1 week?
Yes, if you will be vigilant enough, it will be at least we cannot cover the 100%, but we will cover most of the topics. And what I am planning to do is that topics which we are doing in Telegram, we will not repeat in the live session. Okay, so you will have maximum coverage then. We did last time also the same. We covered almost all the maternal medicine in this way because in the Telegram you have 1 week. That is why I'm encouraging all of you to actively participate in Telegram, and we're going to keep a track of each one of your participation. Okay. So, so topics and the time will go very fast. So take out your time out of 24 hours, at least 30 minutes to do the station. Because these are usually OSCE 10-minute station. In live session, you will have the opportunity to do a long station, okay, which will include history and examination and discussion as well. Clear? So you can check now on Telegram. I posted today the schedule for the OSCE, but it will be in different groups also shared by the team, definitely.
Kindly share the link of Telegram today, like here in the chat.
You don't have the link?
I'm not sure. I don't think so.
You are on which group? You are on, there is
I'm on WhatsApp
MRCPi
only. I'm on, I'm on WhatsApp.
WhatsApp group. Um, okay, then I will ask one of the team member. They are also listening to share. You want me to put in the chat now?
Yeah, it would be great.
Okay, if somebody from the med exam team can share on the chat, I will also try to type. I have the link here. Let me see. Okay, let me type in the chat then. So, any other questions? Any other questions, guys?
I just want to ask about the last task was presented by Dr. Meruna. It was good attempt by her, but I'm just wondering that did we should we mention regarding the hysteroscopy and endometrial biopsy for the postmenopausal lady as a management plan, or like
Yes, yes.
prepel is fine, like because should we discuss all of the options to her and let her to decide.
Yes, this was the actually the task that you have to explain the management, the causes, but actually more than 5 minutes were taken for the history. And this is just randomly we are practicing, so I did not stress too much. But she mentioned biopsy. She said we will take biopsy and we'll do the ultrasound. And she could have just mentioned that we will do a camera test, which is the hysteroscopy to look inside the womb. So that is why I'm saying avoid jargons and familiarize yourself with the layman terms for all the
Ma'am,
uh,
I
medical
want to ask one
terminologies.
thing. Like, if it's a short
Yes.
case, just 10 minutes, then we will focus what the question says and what the examiner is asking me, the lead question or something. But if it's a
Yes, my
long
dear.
case, yes, long case
Yeah.
like 30 minutes or something, then I have a long time. So I can go step by step, like diagnosis and what type of investigation and mode of treatment, everything I can discuss. But 10-minute discussion, can I discuss all those things, or I will only focus the question and what the external is asking me, the lead question?
No, my dear, you will see there will be a role player. There was an exam recall, then the patient had subfertility and she had intermenstrual bleeding, and the role players were there. This was 10-minute OSCE station. You have to take the history, you have to be very fast. That is why I keep the history for 3 minutes. And then
Hmm.
you have to tell her what can be the reasons. Of course, you will examine and investigate what investigation you will do, how you will manage. You have also in subfertility she had two problems. Like she had, then there was an ultrasound report in which there was endometrial polyp. So you have to explain to her the endometrial polyp. She had a family history of cancer. So many things were there. In 10 minutes, you have to cover. This is the art. This is the art you have to learn by practice.
Oh,
Okay. So
yes, ma'am.
similarly, there's a recall about perennial tears. So this was a structured discussion. So you have to tell all about perennial tear, how you are going to manage regarding this history from the patient, then immediate management, later on
The
management,
care, the
complication. You have
hygiene,
to
everything,
tell
medical.
her, no, no, you have to talk about the future implication on her obstetric, on a future pregnancy also, success rate, complications, warning signs, everything you have to speak, how you're going to repair, all the examiner will ask all the details. Okay, so you have to be very fast. That is why we need to practice more. So for Dr. Saima Rashid, I have already shared in the chat. This is the link for the OSCE Telegram group. And below, I am now typing for you for the study material group. Okay. But please don't rely solely on the study material because this is just to support you. There's lots of things on the what we can say this website. Also, I tried to post the related material and I didn't have access, so I've shared on the same group. But this is the link I'm sharing now for the study material. So I am also mm, trying to post related material, but it's not necessarily like sometimes there can be delay because I also get busy at times. So don't solely rely on that. But we are here. This is just to support you guys, additional support. But you have all the information on the
It is
website
showing
as
that
well.
link is expired. That the last
Huh?
link which you shared, the last link which you shared for study material, when I'm trying to join it, it is showing that the link is expired.
No, it's not expired. I tried. I joined only today because I didn't have this link myself.
Okay, thanks.
Okay. So it's not expired. Until this
I
morning, it
want to
wasn't.
I want to ask question
Anyways, you
before
have the
this.
team. You can contact with them. Any problem, technical issues or joining issues, you can discuss with any team member. Okay, just send them message and they will reply. Yes. Oh, okay. Actually, this is the paid. You have to subscribe for these links. That is why. Dr. Saima, hello. Are you listening, girls?
Doctor, I have a question.
I'm saying these are paid groups, so you have to subscribe to join the practice
Right.
if you want to as a regular candidate. Okay. Anything else?
Yes, doctor, I have a question.
Yes.
Like for every module starting on the due date, do we need to prepare beforehand and we are going to present the cases, or it will be a random discussion and we will be given the whole study material and the cases later on that we need to prepare in the 10 days or 7 days period that will be defined for the next till the next module?
Ideally, it should be random because you need to cover the whole module. As I've said, I will try to cover some stations, and this is for the regular candidates. Once you will subscribe, you will be joining the group activities. So, in this group, for example, let's take example of hotel and medicine. So, we will cover some topics in 1 week in the Telegram group, and the remaining topics you will have in the live session. So, in the live session, it depends upon the candidates. Usually, I'm preparing like 6 or 7 stations, 1 or 2 long cases because time factor also we have to keep in our mind. So the session is usually 3 hours long. So we have 10 minutes OSCE station. So if there are less candidates, you have more opportunity to do the station. So 6 or 7 topics we are covering in the live session. Okay.
Okay,
So like
so I mean details for the stations, like which questions are going to come and how
not
we need to.
questions, topics you mean? No, questions we are not going to share with you because then what is the purpose of practice? You should come prepared. If it is maternal medicine, for example, you come prepared with the maternal medicine, we can ask you any topic. For example, we can ask you sickle cell disease, we can ask you epilepsy, there can be station regarding inflammatory bowel disease, there can be station regarding myocardial infarction, anything, right?
Okay, 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 I got now. Thank you. Thank you.
Because if I suppose I say you, okay, prepare diabetes and hypertension and sickle cell disease. So what about the rest of the cases then, right? What I'm saying, topics which we will cover in Telegram, I will try not to repeat them in the OSCE so that you will have maximum practice if you are joining the group. So the
Yeah,
team has already shared. I'm sorry because that was only once you have subscribed. So the team has shared the WhatsApp link below. If anybody wants to contact them to join the regular course, you can contact on the link given in the chat now. Okay,
yes, okay, thank you.
clear? Okay. Anything else? Okay, then we are going to end the session. If no more questions, right? Okay, dears. Good luck and see you in the live sessions very soon. Bye bye. Thank you, all of you.